Let me check the audio to make sure it's good.
To take their students because they have three.
Okay, it looks good. I think we are live. Okay. So, Christina and Ryan, thank you guys for coming on this beautiful Saturday. I'm going to do a little bit of housekeeping and then we're going to turn it over to you two for kind of introductions. But for a quick introduction in terms of the purpose of the video, virtual rotations are being done more commonly now, especially for rotations. You guys are actually the first to talk about precepting PGY-1 residents virtually, so this should be a pretty interesting conversation. And for the format of the video is similar to some of our other Q&As that we've done. Basically, we have a structured list of questions that we're going to go through and ask. Common questions, general questions, challenges, and opportunities. But because we have a live stream, we're also going to field questions from the audience as well. And as those come in, we're kind of flip back and forth. So to anyone that is listening on the live stream right now, feel free to just ask your questions, and then when we get a moment, we'll jump right into it. So that's kind of the format. And now we're going to turn it over to Christina and Ryan with a little bit of background about yourselves. And because this is a clinical rotation, it'll be interesting to hear your thoughts on, kind of a description of what rotation you offer. So whoever wants to start first.
Sure, yeah, I can introduce myself first. Thanks for having us, Brian. My name is Christina Rivera, and I'm one of the infectious diseases pharmacy preceptors at our academic medical center. And I went to pharmacy school at the Ohio State University, and I did a general inpatient PGY-1 at University Toledo Medical Center in Ohio. And then I did a PGY-2 in infectious diseases at Mayo Clinic. And then I've stayed on currently an ID pharmacist, practicing at, as I said, a large academic medical center. Ryan?
Yeah, so my name is Ryan Stevens, and I am also an infectious disease pharmacist. And I graduated from the University of Montana and then did my PGY-1 residency with the Indian Health Service at the Alaska Native Medical Center in Anchorage, Alaska. And then I went to work in critical care at another health system up in Alaska, and then transitioned over to infectious disease in about 2012 and have been an infectious disease pharmacist since. Now at the same academic medical center as Christina. So we sort of co-precept our infectious disease rotation for our PGY-1s, and just sort of a general understanding of what the rotation is. What it consists of is, because we are a large academic medical center, we have several different rotating infectious disease teams. And so we actually split, we take our residents two at a time and we split them. So we have one resident on an infectious disease rotation with an immunocompromised infectious disease service. And then we have a second resident that's on rotation with sort of more of a general infectious disease service at two separate hospitals. And so they do 2 weeks on each service, and then 2 weeks on one service, and then they flip-flop to the other. So Christina precepts generally the immunocompromised side, and I precept the sort of general inpatient side.
Okay, very cool. Thanks for the kind of description there. And just out of curiosity, is it a consult based? So you guys work off consults, or do you just round on all the different patients?
Correct. Yeah. So it's a consult service. All of the infectious diseases services are consult-based services. So.
Okay. So now let's jump into some of the general questions that we have. I guess my first question is kind of answered already. I was curious how many residents you are currently precepting, and correct me if I'm wrong, you said it was two that you split on those two different services.
Yeah, currently we do have two residents, two PGY-1s, and we decided to, as best we can, just try to keep things pretty similar to as if we were doing it in a face-to-face environment.
Okay. And a common question that comes up, especially for logistics purposes, is virtual platforms that everyone is using. What are the virtual platforms that you're using with your residents, and how has that been working out?
Well, I think that we're still kind of learning, with everybody else that's been forced into this virtual environment, especially with a clinical rotation. And so we're still experimenting with different platforms. Our rounds currently are being based out of using Zoom or some different teleconferencing platforms. And so depending on the consultant that may be on service, we're using different sort of telephone versus face chat or video chatting platforms, which has been a really kind of interesting, especially considering the fact that at least on our general infectious disease side, it's a teaching service with medical residents as well. And so they've all been actually working virtual as well. So it's been kind of interesting to see everyone call into the same video chat and have pharmacy and medical residents and ID consultants and ID fellows all called into the same meeting. I know that Christina and I have been experimenting with a couple of different platforms, but even something as simple as the residents that I'm currently rotating with, we will even use things like FaceTime just to touch base after rounds, because it gives you that sense of not quite working in such isolation as even you might think on a phone call or sort of, message chatting back and forth. And so that's sort of the platforms that I have experience with anyway.
I'll just add in too, throughout the day, just having conversations with my resident about questions that come up, even on some of the patients that I follow personally for infectious disease. I might pitch them a question like, what would you do? I got this question today. And I send that over Skype for Business. We also have been using our EMR secure chat function to touch base with the team-based pharmacists, so that maybe it's the internal medicine pharmacist. I have the resident reach out to them through the secure chat just to kind of touch base and make sure that we stay in good connection with those team-based pharmacists, just like we would in a face-to-face type of situation.
Okay, that's very interesting. You guys are definitely using a wide variety of virtual platforms. And I guess you keep the residents on their toes if you're just constantly pinging them with questions, which is good, right?
Yeah, I think it's been good. Like I said, I think we're still sort of experimenting and playing with different things to see what works well. And I think this last week we were able to do some teaching sort of rounds or topic discussions via a video chat platform, via Zoom. And it was very effective, and it was really nice to be able to see the residents face to face and sort of be able to read their visual mannerisms and stuff too, or body language. And so I think that's even in the last week, even I think our preference on platforms is shifting a little bit as we sort of gain a little bit more experience into the rotation.
So I'm very curious, in terms of shifting, are you leaning towards one that has been working better than others or something?
I think at least my preference is I'm leaning towards the Zoom meetings being very effective. I think it's nice. You can chat back and forth. You can share screens, and I can kick it to the resident to let them share their screen. One thing I've been doing a lot as I'm doing some various teaching is I'll share my screen and pull up Paint or some software that I can draw in as I'm like drawing them pictures and trying to explain things or writing algorithms. And then they can follow along with me, just like if I was sitting at a table with them, writing it on a piece of paper. And so my preference, I think, is shifting more towards the video meeting with the chat functionality and the screen share functionality.
Yeah, I agree. And that's kind of one of the things that I mentally had been thinking about as a pearl to share with folks is that shift. I started off using global crossings, and we got feedback from the residents themselves that they did like that face-to-face functionality that Zoom has, or maybe it's some other platform that has that camera function where you can actually see each other, even when you maybe aren't having anything to show them. Maybe you're just talking about a patient, but it is really nice just to have that visual contact with your residents so you can read like physical cues and things when someone might want to talk. And it's I think improved the rotation already. And now I've moved all of my global crossings meetings with the residents over to Zoom that I have planned.
Very cool. Yeah, you can see.
And just another.
Go ahead.
Just another sort of random thought as well is our teaching service turned over this last week. And so it was the new group of medical residents first week on service. And the consultant that we had on service likes to use the teleconference instead of a video chat. And so it was interesting because our resident had never met any of the medical residents on service. And so she was just talking to them on the phone all week. And she said it was kind of hard for her to gauge, who they were and sort of read their language and get to know them. So just developing like a personal relationship and sort of a professional relationship with this new group of folks that she was working with was challenging because she didn't have that level of sort of visual interaction with them throughout the day as well, versus the previous group, when they were on their last week of their infectious disease rotation, we all used the video chat functionality, and she just felt like she got to know them much better.
Okay. Yeah, I certainly agree. I mean, just more personable, more human. You can see a face, right? And you can see if your resident's using notes. Okay, so we can segue to another question here. So it does sound like you're interacting with the residents throughout the day, but how often are you meeting with your residents? Is any of this, are you structuring it? Are you meeting with them daily, weekly? Like, what's the actual time you're interacting with them? What would you equate that to quantitatively?
Yeah, I can start off with that one. So actually, for me, this has kind of led me to have more calendared time with the resident, because I am putting a Zoom meeting on their calendar and my calendar to do pre-rounds. So I'm doing 30-minute to 1 hour daily pre-rounds. Now, I'm more of a pre-rounds person to go and talk about the patients, and Ryan can speak to his experience. He does it a little bit differently. And so about that block of time, Monday through Friday. And then I'm actually Zooming into rounds as well, and being there for virtual at the elbow support for the resident. And rounds vary, as it can be this consultant dependent or staff dependent. So it can be anywhere from 20 minutes to 1 hour. But the nice thing with the virtual platform and the virtual rounds is that I can also kind of keep an eye on my other work queue. And if something urgent pops up, I can pop off that virtual round and take care of that issue and then pop back into rounds. So I've actually found that it works pretty well with my regular work day. It's better to have virtual rotation than the in-person face-to-face rotation. So that's kind of what I'm doing daily. And then Ryan and I split topic discussion and a patient, like a deep dive patient discussion through the week as well. So we each do one topic and one deep dive patient review with the residents per week. So it's a total of 4. 4 times we meet with them, and they're scheduled an hour. Sometimes we go over. We like to talk. You can tell this already. So I guess it really ends up being 2 hours to 2.5 hours or less per day.
Okay.
Yeah, my general preference is I like to round, and while I'm rounding, it seems like there's lots of little pearls and sort of clinical discussion points that come up. And so I like to meet with my resident after rounds and sort of do a post-rounds debrief every day. And so if I'm at rounds with the resident, which I try to round as often as I can, typically at least 3 times a week, I round with them. And if I'm at rounds, maybe it's just a short debrief to talk about questions that came up or things like that. Generally, we've been doing that via FaceTime just because it's easy. And then if I'm not at rounds, then usually we'll schedule a sort of debrief at some point during the afternoon where we can sit down and she can run the list with me and kind of explain to me what each patient on the list, what's the update for the day, and kind of keep me in the loop on things. And so then, like Christina said, we split the patient discussions and the topic discussions, which really is nice because it gives the resident a little bit of variety to the way that we sort of alternate days. The one thing I'll say that sort of echo Christina's comments is that it's really been nice on a big academic campus to be able to just virtual into the meeting. It's extremely efficient actually to virtual into rounds and have virtual rounds. I would also say that sometimes I feel like maybe they're a little more efficient just because they're being done virtually. And so they really roll quickly, and it's kind of nice. That's been great. And then outside of rounds and sort of the structured time with the preceptors, because the general inpatient service is a teaching service, our resident has had the opportunity this week to do things like she met with the medical residents and the ID consultant and one of our pathologists and microbiologists in order to view some fungal stains that they were showing images of, and doing some teaching on some different microbiology rounds even that were being done virtually. And she's had the opportunity to call into some of the medical resident teaching sessions and sort of didactic sessions that have been great opportunities for her to learn while the ID fellow or the ID consultant's teaching the medical residents their sort of core curriculum. And so lots and lots of opportunities to call into different venues and video chat into different venues that I think has really offered just about as diverse an experience as being on campus. And even things we were just talking yesterday that like microbiology rounds, I'd actually love to see those even sort of after COVID. I would love to see those have some sort of a virtual dynamic or the possibility of a virtual dynamic, because it can be hard for me to make it all the way down to the microbiology lab for a 30-minute rounds and then make it all the way back to my office. But if I could call in and view them from my office sort of while I was, doing other work or without having to leave the building that I work in, that would be really efficient. So I sort of see some changes on the horizon, perhaps.
Yeah, it is very fascinating to think about the efficiency perspective, especially given the campuses and how large they are from traveling back and forth. Okay, so let's talk about some of the activities that you actually have the residents do. And we kind of have two parts here. One is direct patient care activities and then non-direct. But starting with the direct patient care activities, what are some of those things that you typically would have them perform?
Yeah, so I can start with that. So for direct patient care type of functionality, I think one of the biggest things that we have them do is really do a comprehensive profile audit on every patient every day to make sure that their infectious disease therapy is sort of optimized in a lot of different dynamics in the same way that they would do if they were on campus. And they're looking for things like adjusting doses and optimizing drug selection and helping the team with appropriate durations of therapy and or de-escalation opportunities. And so their functionality of doing these profile reviews and sort of optimizing the pharmacy dynamic or pharmacy component of infectious disease therapies, I think really the bulk of what we're having them do, especially things like drug-drug interactions and screening for that, contributing to the team with information on that, as well as, like I said, pharmacokinetic and pharmacodynamic dosing optimizations. The other interesting thing this last week that our resident had an opportunity to do was she actually got to counsel a patient on some new antifungal startups. And she actually called the patient, and her and the consultant touched base before rounds. The consultant was on service and on site. And they agreed on some patient education material. The consultant printed it out and handed it to the patient when he saw the patient that day. And then our resident actually called the patient on the phone and did her counseling over the phone. So she was still able to actually have some patient interaction, even being from home, to contribute to that sort of aspect of clinical care.
Yeah, that's fascinating. I think that was kind of what I'm curious about is how much interaction they're having with patients. But that you're saying that's new, that you just started doing this past week?
Well, I mean, we've just really been precepting virtually for a very short amount of time. But this last week was really the first time that she's had the opportunity in order to do that with a patient. I think it's definitely possible, and there's definitely more opportunity to interface with patients, and I think that you can do that, via video chat and sort of video visit, virtual visit, or it could be done via phone call. In this circumstance, it was just sort of going to be easiest for the team, for the consultant and the resident to coordinate on the education materials. And then the resident already had the materials when she called the patient, and she sort of worked through them with him on the phone.
Okay.
Yeah, and I can piggyback a little bit and share a little bit of our HIV clinic rotation experience, just that it speaks to this particular question pretty well, that we do a lot of direct patient care there. And we had a resident in learning in our HIV clinic when everything transitioned from face-to-face to virtual, right kind of in the middle of that. And we converted all of our patient appointments to virtual appointments pharmacist patient. And if the patient had capacity for video, they would video with a pharmacy resident. And if they didn't, then it would be a phone call. And we meet with the patients and ask them all the same questions about medication adherence and adverse effects from their HIV medications, just as if we were meeting with them in person. So I know the resident was involved in that too and was able to finish out her clinic rotation, which was pretty amazing to me, but it was doable.
And out of curiosity, are you usually in those meetings as well? Or is it just the resident and the patient?
We were fortunately, this was a PGY-2 who is quite an advanced PGY-2. So she was able to, and it was, she'd already had 2 solid weeks of working in our clinic with the patient. So she had some pretty good experience already. And it was sort of at the elbow next to her when she would video or call with the patient. So if she had any questions, she could ask us right there. But she was the primary one just doing the appointment with the patients herself.
Very cool. Very cool. And I guess part of the reason why I asked the question is trying to tease out any differences in what you were doing before COVID. And so kind of a direct question here to either of you is, has there really been any differences in the activities that you are doing now versus before for direct patient care?
Well, for us, on my side, I don't think there's been a lot. And I think we're adapting quickly to be able to make sure that the opportunities that were available previously are available now in a virtual environment. So we're adapting. However, I do think that, depending on the consultant that's on service, there's the different propensity to be able to go and actually do walking rounds with the team and see patients at the bedside with the team. And that's the one dynamic that's potentially would be difficult from the virtual rotation. You can get the Zoom rounds, you can have that sort of interaction and environment, but it's that actual, bedside with the team examining a patient that I think there's some very specific benefits in that kind of a learning environment that just really are not going to be possible virtually. But like I said, I've been really encouraged to see even things like microbiology rounds and things like that moving virtual to where some of that experience doesn't have to get cut out from just being online.
I agree with Ryan, and even maybe a little closer to the same from like a clinic perspective, medication therapy management, which is now called medication management services, because you can do a video visit with a patient. And for a pharmacist, we're actually really well positioned for video visits because we don't typically we usually aren't doing a physical exam. And so most of what we do with patients is cognitive. So pretty close to being able to replicate everything we were doing before in the virtual environment.
And this just kind of came into my head. I had a quick flashback to when I was a student and I was on my ID rotation, and some of the things I found beneficial, or what my preceptor had taught me at the time, was like, when you're evaluating a patient that has an infection, just because they have sepsis, sometimes it's good to go to the patient's room, see how they're feeling. Do they look like they're clinically improved? Just to see that, connect the objective lab values and how they're doing in the chart with the actual patient. And then the second thing I was thinking, because I was on an ID rotation, a lot of patients had MDROs, and I had to do a lot of good PPE, which is probably good practice, right? Really learning how to put it on and dispose of it properly. But I guess that can come on after COVID, learn that kind of stuff.
Better to have your PPE technique down first.
Yeah, there's definitely a distinct benefit in some areas of infectious disease to really laying eyes on something. And that's where I think to be able to stand at the bedside with the consultant and with the team and say, look at this drug rash. What does this look like? What are the characteristics? Or look at the margins of this cellulitis, or different things like that, I think are really beneficial for learning and being able to equate the future problems with sort of what you're seeing and sort of that, like what we call academic detailing, right? Where we're like learning from a very specific case and carrying that forward into the future. And so that's the one dynamic that I think is a little bit tough, and that I would love to see or have sort of have that be expanded if possible virtually. Although I think, just until we get back on campus, it's going to be a difficult proposition.
Yeah, I'm curious because I know that you can take pictures, of patients like infections and send it straight to the EHR. I wonder if they're maybe they are doing that already. I wonder if it's utilized a lot for that. Okay, oh, go ahead.
Go ahead. I was going to say, oh, sorry. Yes, I have heard that at the institution we practice at, they are putting some tablets in the room so patient can physically see the patient, or the medical team can physically see the patient, I guess, can see the patient through an electronic medium. So they are working on solving that problem. So we'll see how close it gets to being there actually face to face.
Yeah, it'd be really cool. Okay, so let's transition to non-patient care activities, and you kind of talked about topic discussions that you have with the residents. Are there any other non-direct patient care activities, and examples that come to mind are like any type of guideline revisions, presentations? Like what kind of non-direct patient care activities are you having your residents do?
Yeah, Brian, we have a project that we have the residents working on, which is very timely. There's been a recent release of vancomycin monitoring guidelines from IDSA, SIDP. And so we've put our residents to the task of reviewing some of the literature behind that. We're making them step through that as an exercise to see what they found, and then present that to us. And then we're asking them to make background slides for our pharmacist core, our enterprise stewardship pharmacist core group meeting. And that either we will take forward or they can take forward depending on timing and their bandwidth and things of that nature. But this is something that we had been planning on doing a project in a face-to-face environment, and we just carried it forward as well in the virtual environment. And it's a work in progress for Ryan and I, these kind of project-based things. And I think it kind of speaks well to the fact that in this environment where you're trying to figure out how to do something virtually, if you were working on something or it was sort of a work in progress before, that element doesn't go away. We're still trying to kind of figure out with our projects what the right scope is for them and how we want to do them. And that was before the pandemic. We're still trying to figure that out during the pandemic. And then we added on this other layer of the whole thing being virtual. But thankfully, because of what we have figured out with the Zoom platform and that really working well for us, we're able to replicate that doing a project in the virtual environment fairly easily. So we're just kind of really focusing on this scoping part. So we gave them the assignment during our pre-rotation meeting, and Ryan had put together a really nice document that described what the project would be, and we went through that with them over, I think our pre-rotation was global crossings, wasn't it, Ryan?
Yeah.
We hadn't discovered the Zoom yet. Yeah. So that was, but we went through that. We had them just pull up the document electronically. We talked them through it. Then we put another meeting on our calendars for a week into the rotation, the beginning of the second week. And they talked through their findings, and we did use Zoom for that. And then we just touched base with them again here at their midpoint about what the next steps are going to be for the project and the timeline. That's a main one. Other ones, Ryan?
I suppose like another sort of, I guess you could call it non-patient care kind of activity is we do have three sort of structured learning topic discussions that we assign throughout the week. And they do one specific discussion with Christina and one with myself, and then they're assigned one as an independent learning or a self-study topic. And so at the beginning of their rotation, I sent them a test. We have a pre-test, post-test, and they filled out the pre-test, post-test electronically and sent me their answers back. I graded the test. And then based on their answers and their grades in different infectious disease domains on the test, that's how we determine which specific topics should be taught by a preceptor and which are appropriate for self-study, and which topics they may already know well enough that they don't need any further study on as a pair. And so one of the ways that we do this is we have cases developed for some of the different topic discussions. And so we'll give them the reading for their discussion, but we'll also assign the case. So in a virtual environment where we're really assigning these things and we're letting them do these relatively independently without the direct oversight of the preceptors for some of the self-studies, I think the cases have been very well received because it gives them an opportunity to sort of work through a patient scenario with questions written by the preceptors to make sure that they're actually getting out of the reading what they really should be getting out of the reading and how they might apply that to an actual clinical case. And so I think that's been something else that's been sort of helpful or interesting in the virtual environment is the way that we have structured our topic discussion selection and the way that we've structured the actual discussions themselves.
I think that the dynamic nature of that is really cool. How you're adapting it based on how the resident does on the exam. Though doing any type of exams is kind of stressful as a resident. But anyways, as we're going to move on to some of the more interesting questions. Those are just our basic general questions. So we're going to talk a little bit about challenges and opportunities. But before we do so, I do want to say that anyone that is watching, don't be shy. Ask questions. Feel free to let them trickle in. And we're going to keep going on with our questions here until we see one from the audience. Okay, so let's talk a little bit about challenges. This is kind of open-ended here. So what were some of the barriers you encountered, especially when you first started precepting virtually?
For me, I think the biggest barrier and the biggest frustration that I encountered initially was I'm a talker. I'm a very social person. And so being isolated, working from my basement, knowing that there was a resident somewhere in the city also working from, whatever environment they're in, it was hard and it felt kind of disconnected and like I was unable to really, I didn't feel like I was providing a real great rotation or like I was giving them the presence that they needed in order to, especially early on in the precepting sort of structure of modeling for them what it looks like. I felt that specific dynamic was challenging. How do I model something for someone when I'm not actually present with them? That was difficult. But as it's gone on, I think that's where I think the video chat has become really critical and really crucial is that it gives them a different sense and it gives me a different sense of presence. And so I feel more present with them and I feel like I'm able to actually model for them the roles of an infectious disease pharmacist. So then I feel confident that they may pick it up themselves and be able to sort of coach into independent learning. And I can really facilitate their independent learning as I'm able to watch their nonverbal cues on video chat and understand sort of how confident they are with the content or how confident they are with the given team. So I think that's been the biggest sort of challenge for me is figuring out how do I model this and actually assess someone's readiness to work independently.
Yeah, I'll just speak to another challenge. It's a similar challenge is integrating that resident into the team for some of those curbside type questions. And oftentimes our team that I usually immunocompromised host team that I traditionally work with, we will have the resident work in what they call the bat cave with the team together. So it's like you can kind of imagine it's a small team and they kind of sit in a smaller room together. And we have the resident join the rest of the team there so that if questions come up like, oh, a new consult came in and we don't know what vancomycin dose we want to use, the resident is physically there. And then it's really obvious that the team can just turn and ask the pharmacy resident their question. But virtually, I've been trying to encourage that. And then I asked the resident to send a Skype for Business message to the ID fellows and say, hey, I'm here. If any of these kind of questions come up that are not during formal rounds, if you want to ask me about dosing or drug level that comes back, you can chat those to me. And it sounds like from the resident that it's just not quite the same amount of questions and traffic the pharmacy resident gets whenever it's just this virtual. It's out of sight, out of mind, honestly, just a very simple thing. When the person is sitting there in the rounding room with you, it's very easy to ask them that question, but it's really harder, especially because the ID fellows don't know these residents very well, whereas they might ask me and Ryan questions more rapidly over like a chat. They might not think to reach out to someone they haven't been working with for months to years already. So I'd say that's kind of the biggest challenge that I'm seeing, and it's more directly related to what the residents' experience is really.
I think as you're talking about that, I was thinking if like replicating that virtually, like a virtual cave. But then again, I question whether or not that would be effective either if people would just join and chat about random questions versus being right next to someone. But okay. What about policy changes? And it could be from any group, whether it's your own organization, ASHP, or state policy. Have you run into any issues with doing virtual rotations? With, yeah, any challenges there?
Actually, shockingly little. I think we got some mixed messages initially. We had heard from some of our partner sites that they were told to change their learning experience to say that it could be on site or virtually. But then when we talked with our local residency leadership, they said that wasn't required. So it was a little bit of a mixed message there that I think kind of maybe got a little confusing to me at least. But since we've had that element cleared up, we actually have had surprisingly few barriers, if any at all. I think that if we wanted to expand it, which I think is a neat idea, and maybe take some residents that are in other states, that we may see more barriers from a like accreditation and licensing and things of that nature standpoint.
Yeah, the policy issue was pretty huge, especially for APPE students, because all of a sudden, talking with Jen last time, there was about 80 to 90% of their students that had hospital or clinic rotations. It got canceled. They couldn't go to their sites, so all these students were displaced. So the ability for ACPE to say you don't need things like an affiliation waiver, you can go do virtual rotations, not only non-clinical, because they later expanded it and said you can do both clinical and non-clinical rotations virtually. And that basically opened it up for all these schools and sites to connect and do virtual rotations. But I guess in this case, the residents that you're precepting is affiliated with the organization. Okay. So probably
Correct.
a lot less policy kind of barriers there. So that's good. That's a good thing. So not many challenges so far. Next challenge question is, do you envision any future challenges that may be coming down the road, especially now that we're transitioning into this new cycle of residents that may be starting that might not have been present with your current batch of residents?
I think one nice thing, I guess, about the timing of all this is that one of the residents that's on rotation is somebody that Christina and I have actually been doing his research project with him throughout the course of the year. So we know him well. We've worked with him in a lot of different environments. We sort of understand baseline strengths and weaknesses fairly well up front. And so we kind of knew what we were getting there. The other resident is somebody that I've also worked with on some quality improvement stuff over the course of the year. And so we had a pretty good understanding, I think, of these two residents as they were coming in and kind of where their career trajectory was going. We always try to tailor the rotation as best we can to someone's career trajectory. So we know that both of these current residents are going to be staying on for various PGY-2s. And so that gives us the opportunity to kind of understand where they're going and best tailor the rotation for their needs. And so I think it could be definitely challenging as we bridge into a new class of residents. where maybe we just have less of an understanding of them as individuals and sort of baseline strengths and weaknesses, and also potentially have less of an understanding of where they may be placed or sort of where their post-residency placement might be. And so I just think it'll be important to establish clear expectations and goals up front, and then also just to be sure and have a sort of an open line of communication as we try to figure out just the personal dynamics and the relational dynamics between a new group and sort of an existing group of preceptors.
Yeah, I think it'll be really interesting, or maybe a little tricky to figure out when some service lines return to face-to-face and some are still virtual or remote working. So how do you manage when maybe the ID team is still virtual, but the residents are back on campus? Like how does that look? I mean, I don't think it's a major barrier, but I do think there can be some technicalities and some, you're going to have to reinvent the wheel again potentially with that. And, maybe we don't know, maybe some things will just stay virtual and going forward permanently. And so we don't know how to anticipate that. We don't know where things are going to go. So how do you build and form what your stock rotation is when you don't even know what format it's going to be in the future? So I see those as challenges, but obviously, and we'll talk about opportunities. I mean, it's also kind of exciting to think about, wow, I mean, what is this going to be? Things are different, but that doesn't necessarily mean that different is bad. Different could be better. So I'm looking forward to tackling whatever the future brings.
Yeah, that brings up sort of an interesting dynamic too, Christina, that like, as we move forward and, we've had sort of our hand forced in this transition to a virtual environment from stay-at-home orders and sort of the moving of teams off campus. But what will be interesting is when potentially there's a mix of different rotation types. Someone's doing an emergency rotation on site, immediately followed by infectious disease that might still remain virtual. And so right now, the residents, I think they have a pretty good understanding, and even Christina and I are adapting and sort of actually really enjoying precepting virtually. And I think what will be difficult is if there's a lot of back and forth between on-campus and virtual and on-campus and virtual. It could be hard to develop any sort of a rhythm that would really facilitate the kind of like longitudinal learning that we really hope that a resident picks up rotation after rotation after rotation, if sort of the setting is changing from in-person to virtual and back and forth. And so it'll be interesting to see the dynamic that sort of unfolds as teams start coming back to campus, because I think from an infectious disease standpoint, it has been really interesting that honestly, I think Christina and I have really been able to the best of our abilities to facilitate 95% of the rotation that they would get on campus virtually.
So two kind of follow-up questions that was kind of circling in my mind as you guys were talking is one, I mean, if you're having this flip back and forth, which I imagine will occur as they transition from rotations, it's probably difficult to, work in your pajamas versus like working in work clothes. That's one. That's at least that's for me. That I think that would be a struggle. The second thing is, what would you predict in terms of your ID rotation going back to in person? Like if you could even guess, do you think you're going to be doing virtual rotations for another couple months? Like what would you project doing this for? How long?
I think that's a really good question.
I will say that I want to keep, even if some elements of the rotation go back to in person, I would like to keep some elements virtual going forward, because I think there have been really great gains in efficiency by doing that, like we mentioned before. And also it's been really great to be able to be in, a lot of times Ryan and I have to split the meetings or topic discussions, and every time we meet with the resident, often there's only bandwidth for them to meet with one of us because the other one can't travel to where we're meeting. So I would like to keep a lot of it virtual so that it facilitates me being able to meet as a group more frequently. So whether maybe the hospital rounds go back to being in person and face to face, but I would like to keep a lot of my meeting with the residents virtual. I think it really has a lot of strengths to it.
And I think my office environment, and I think I know Christina's office environment, is not necessarily really conducive to being able to facilitate group discussions. And so therefore, for these discussions, a lot of times we're having to leave the office and go to a sort of a neutral location that's more amenable to sort of that kind of conversational topic discussion or patient review. And so there's a lot of traveling and a lot of back and forth and sort of moving around. And I think that moving around, especially on two campuses that are both very large and both sort of separated from each other geographically, that can mean a lot of sort of wasted time in transit. And so the efficiency of being able to do it virtually has been really key, I think, because it's cut down a lot of the inefficiencies of the constant travel, or where are we going to meet, and is it a location that's secure enough for us to have patient-related conversations, and also, quiet and private enough for us to have topic discussions.
Yeah, I would love, well, maybe I don't want to see, but I would like to see an analysis of how much time I had previously spent just booking rooms for me to meet with the residents alone. All that time that I got back, that now I can just schedule a Zoom meeting. It's been really nice. So I don't know about the hospital based, like as far as like the hospital rounds. I don't know when that'll go back to face. Maybe it'll stay virtual, but I know that I'll keep a component of our rotation virtual.
Okay. Yeah, it's fascinating. I'm curious, beyond your rotations, how everyone else will plan on doing their rotations in the future. Because I imagine a lot of folks that are doing this virtually see the efficiency gains in doing some of these activities virtually. And I don't know if we lost Ryan. Looks like his screen is.
Can you guys still hear me?
Oh,
We
yeah,
can still hear
we
you.
can hear you. You're just all gray.
Sorry, my bandwidth is slow here.
No worries. Okay. Good segue though into opportunities, because it sounds like you guys already started talking about that. But I guess let's see if there's anything we can add. So the first question I have for opportunities here is, based on your experience thus far precepting residents virtually, what are your thoughts on what can be improved, if anything?
I can, one of the things, and we kind of asked our residents to give us some ideas here too, and I like some of the ideas they had. One of our residents mentioned specifically that the rotation is just a lot of screen time. And so she thought it might be good to incorporate some podcasts in instead of readings for our, for the rotation prep for topics. And so that's something that we plan to look into in the future, is in assigning some podcasts for the residents to listen to learn from in lieu of readings. So that was one thing. Oh, yay, we have Ryan back.
Figured it out. Yeah, I think the podcast, I think the increase in screen time was a really great piece of feedback that we got from a resident. It was a very thoughtful comment. And it definitely received well by both Christina and I, to try to come up with different ways of teaching that will get them away from a screen, which I think is really important. So whether that's pre-recorded content from preceptors, or whether that's sort of national podcasts, the Society of Infectious Disease Pharmacists puts out a great sort of podcast. And so whether that's sort of external or internal content, I think there's opportunity there. One of the other things that we've done is Christine and I are always asking questions of our residents, and we encourage them to reply to our questions with an email to the whole group, to Christina and myself and the other resident. And so we a lot of times will have these email chains that will volley back and forth. And as you can imagine, there's different perspectives with lots of different shades of gray and ID. And so Christina will have a perspective and I have a perspective, and the residents have follow-up questions, and the email chains can get sort of daunting as time goes on. And so we've actually talked about potentially moving to more of like a Slack program, or some sort of like a Slack platform, to facilitate sort of ongoing group discussions with the ability to upload, literature or documents and share information back and forth. So that's another possible opportunity, I think, that we're both excited about.
Yeah, one other idea that we chatted about, and this is also stemming from, like I said, we've been kind of trying to figure out the scope of our projects in for the residents. And one of the ideas that we had is, instead of giving them sort of a full-blown project to work on, maybe we ask them to do a tutorial, an infectious diseases tutorial that we can post to. They have the residents have a Twitter account, pharmacy residents at our institution. So maybe their assignment instead is to come up with either like maybe a case that they post there, or something similar to that. Ryan's more the Twitter guru. I'm the Twitter noob, if you will. But I thought that was something that we came up with that we might try on a future rotation.
Oh, go ahead. Keep going. Keep going.
And I think that's something that could be, it uses like a virtual platform, but that would have been something that we could have done even on, if most of the rotation is, other parts of the rotation is face to face. That's something we might just try in the future.
Very, very interesting. Yeah, I wonder how much more that's going to evolve too in terms of different types of maybe non-traditional learning. I know I did a presentation on social media learning in the past, and there's a lot of literature from medical, nursing, pharmacy, just all the different health professions doing teachings through podcasts, Twitter included, especially at conferences. Um, I like that Ryan plugged the podcast for Society of Infectious Disease. This is a great podcast, especially for infectious disease. Definitely a must listen. But I also want to, I don't want to say plug, but I understand that you both created your own podcast too. Is that correct?
We recorded a podcast, yes, with the Mayo Clinic Talks. We did an episode right at the beginning of the COVID pandemic, looking at the French literature around hydroxychloroquine and azithromycin. But that was just an episode of the Mayo Clinic Talks podcast. Yeah.
And I'm assuming that's not public then.
It is public.
Oh,
Yep.
it is public. It is public.
Mm-hmm.
Okay,
Mm-hmm.
so we
That's
plug we plug that. Okay, very cool. Very cool. And so you only have one episode though.
That is true.
Plan to
That is
do
true.
more?
So far, I've been kind of putting that idea out there too, maybe a homegrown type of thing going forward, but we'll see. There's so many great opportunities out there that we can only tackle so many, but you never know.
Because like, what if you shift it up a little bit and had a resident do that as a project? What they learned from the Vanco guidelines and have them turn that into a podcast, whatever their rotation project is. And then you can build a kind of a repository of podcasts from residents. Okay, anyways, got me a little excited there. This is another open-ended question for opportunities, but especially for those individuals, in the beginning of March and April, a lot of individuals were struggling on how to operationalize virtual rotations, and clinical was not even on my mind because I have no idea how you can do that. But what tips do either of you have for individuals that are looking to do virtual clinical rotations? Because I'm fairly certain that there's individuals out there that are hesitant to do so. So what kind of tips or advice would you give to those individuals, preceptors?
I think my first piece of advice would be just don't give up. I mean, it seems like the first gut response is to sort of say, this is not possible. I work in infectious disease, and it's not possible to shift a rotation virtually. But when you actually stop and take a couple of steps back and think, what do I really want my resident to walk away from this rotation with, or my student to walk away from this rotation with? What am I hoping that they're going to learn? A lot of times what you're really hoping they're going to learn, they can learn from structured discussion with preceptors, from structured discussion with multidisciplinary teams, and from self-study and patient review that can all be done virtually. And so I think our gut instinct is to say it's not possible to do it remotely, but I really think that it is. And the closer we look at it, the more you think, I can teach the content that I need to teach, and I can allow these residents to get a good experience and to see very similar things, if not the same things that they would see on campus. And I can do it virtually if I actually optimize the use of different platforms like Slack and like Zoom and like the secure chat in the electronic health record or Skype for Business, and you really understand how to use some of these different platforms, I think you can get what you need to get done. So I would say just don't give up, is probably the first step.
And I'm just going to add into that. And in my mind, I hear a lot of people kind of say, well, when we go back to normal, when things go back to normal, I really think that normal it's going to look totally different going forward. And I don't know what component of our work as pharmacists and our work as preceptors is going to be done virtually, but I think that things will look different in the future. And I think there will be a large virtual component. And every time a door closes, a window closes, a door opens. And so even though there are challenges and it is intimidating, I was intimidated too, like Ryan said. I am so glad that we took on this rotation because I just feel like a door flew open and I saw the light and I was like, oh, this is totally doable. And I think it's here to stay in some shape or form. It's here to stay, and embrace it, embrace change, because there could be really great things that come out of trying this in a virtual environment. And some of it is going to be learning as you go, birth by fire. You might try a platform, oh, that one doesn't work, try a different one. And that's okay. I think the residents and the learners, the students are along for the ride with you. They understand, and they are, we have great residents we work with, really like world-class residents. And that's even accentuated now. Like, there's this extra layer of gratitude that we've taken the chance to do this as a virtual rotation. And I think that it means a lot to them. And so just take that opportunity, grab it, and run with it.
And Christina's humble, so she won't say how good she is at rotation calendars, but she is the master of rotation calendars. And so I'll say that up front, she does a fantastic job of helping to establish sort of what is the expectations of the rotation. Because it's split preceptors and split campuses and split rotation sort of services, it can be hard to keep it all straight. So in my previous institution, I may sit down with my resident every day and sort of say, okay, here's what we got on the schedule for today. Or maybe even sit down with them at the start of the week and say, here's what we've got on the calendar for the week. But because of the way that it's split, at baseline, I think Christina has done a great job with the calendar. And now that it's virtual, I would say any preceptor that's thinking about precepting a virtual rotation should set up a rotation calendar and be able to give that to the resident at the pre-rotation meeting that clearly defines what meetings they should be at, what kind of learning opportunities will exist, when topic reviews will be, when patient reviews will be. And it really establishes a framework for the entire thing. And so if we hadn't had a calendar that said you have, training with the ID fellows on Friday, and you have, case review conference on Thursday, and patient discussions with Ryan on Friday. And if we hadn't had that kind of a calendar structure, it would have been really difficult. But because the expectations were clear up front, I think it really streamlined the process and sort of set us up for success.
Yeah, and I'll just piggyback. Thank you for bringing that calendar up, Ryan. And thank you. I kind of feel like a calendar Nazi sometimes, so I'm glad to hear that you're not just totally like, oh, there's a calendar Nazi again. But I could see where with like students, and I think I got this as like even a tip from your interview, Brian, with Dr. I think it's Waith. Previously is that you don't actually know when in a virtual environment, like when the residents start working and when they stop working. You have no way of knowing versus physically, when you can at least meet with them physically and there's an expectation they're on campus from certain times from their residency. And I think with students, that might even become even more critical to set that expectation at the start, to say, okay, I expect you to be online and working on this rotation from 7:30 a.m. to 4 p.m. And I think that could be good to set guardrails with them. And, you don't necessarily need to have them check in anyway, but maybe you do, especially I think with students, it could help to have like even a brief check-in in the morning, like just ping them a message or have them ping you a message, make sure, hey, you're there. And then at the end of the day, hey, you're done and you're signing out, and kind of set up those expectations of when they should be working on their rotation and when they should be taking a break.
I love the calendar comments that you have made. I think all of us who are pharmacists are type A personalities. If everyone has ever looked at my calendar, I'm the same exact way. And I think, especially right now, is probably very appreciative in work from home environments because there's no visual cues in terms of when rounds happens, when the team is moving, or when certain things happen. So having some structure for residents, speaking as a former resident, it's very, I imagine it's very helpful as some guidance. Um, okay, we have a very shy audience. No one's been asking any questions. Maybe they ask some questions. To the segue that I'm about to say, which is in the comments, I'm not in the comments, in the description of the video, I've left Christina and Ryan's Twitter accounts. So you guys can at them if you have questions. Um, but I'm curious is if the podcast that you did, uh, do you have any issues with me posting that in the description of the comments so people can check it out and no problems? Okay.
You get posted. I will say that the data is outdated now,
Oh,
but that's pretty much the state of like affairs completely all the time with coronavirus. Is like you get interviewed or you talk about a study one day and then the next day it changes. So people are absolutely able like to dial in, and I think a lot of the points we talk about are still very valid and actually have borne out in future data some of the concerns that we had. I would just caution to say that there are follow-up studies, a lot of other studies that have come out on the same topic. So the data isn't exactly like the hottest off, like hot off the press anymore. But I think some of the points that we make in it are valid. And we have a couple other, I know Ryan did an interview on convalescent plasma that people might want to also check out, which I think is on Contagion. We can send that link as well. And Brian, can we ask you a question?
yeah, I didn't expect that, but sure.
So how do you see, like from your perspective as an informatics pharmacist who has been doing this like virtual work much before we have, how have you seen, or how has your viewpoint of kind of seeing everybody kind of coming over to your side, what kind of things have surprised you about it, and what kind of things were you sort of expected, like, oh yeah, I knew that was going to be the way it was going to go down?
It's been very entertaining to see people make use of virtual platforms for the first time, sharing their screens, and doing things. Um, but at the same time, I would say that it's been one of the most rewarding things to see how collaborative and positive people are. I think it's been wonderful, and it's it feels good for me too because like they would like, hey Brian, how do you do how do you do this? So I feel like I'm important. I was like I can teach you how to do some of these virtual things, but no, it's just been entertaining to watch everyone come over to the virtual world, and then it's just been very positive because everyone else is helping each other out, um, and I feel as though it's been more collaborative than I've ever seen it because people are talking across state borders, across national borders, across disciplines, and um, that's been very very good feeling. I don't know if I answered your question.
Hey, that does awesome positivity. And I would just say too, more along the lines as far as sharing and collaborating, you mentioned, yeah, I think Ryan and I are both very open about sharing a lot of the materials that we have on our rotations. So if anyone's interested to say, hey, check out our calendar or anything like that, we can, in the very least, talk about what we have and share and collaborate with any other people that are out there looking for that kind of advice or materials from us.
Yeah,
Definitely.
maybe I'll add that. So if there's anything that you are open to publicly share, uh, just send me an email with any of those things, the links, the documents. I know there's been a lot of programs, especially the ones that are a bit more tight on resources, have struggled, and they've been asking around, like, what are you doing? What are the types of activities outlined? Just examples
Hmm.
have been very hard to come by. So sharing any of those details, I think, would be very, very helpful to others who are trying to do the same thing. But that's kind of it for the interview. It's been fascinating to hear, and it seems as though it's been going extremely well. Um, Way better than I was thinking, actually, which is good. It's good. So I just want to thank you both for your time on a Saturday again, um, and hopefully maybe we can do this again in the future sometime.
Thank you, Brian.
Yeah, thank you, Ryan.
All right, let me end the stream.